Hey everyone. So next Tuesday, November 7th, will be my first day at the People's Community Clinic in Austin seeing these MAP patients, and you may be seeing them as early as Wednesday next week. And so I wanted to get this information out to you to give you a little background on the study that's going on there, why we're involved, and some logistics involved with the whole process. The study is looking at how early physical therapy and conservative management, including physical medicine and rehab, what that can do for affecting the transition from acute low back pain to chronic low back pain, and hopefully reducing use of opioids. So all these patients will be ones with acute low back pain episodes, and they're defining acute as less than 3 months. And it could be acute on chronic. I did clarify that it could be acute on chronic also, but current history of less than 3 months low back pain. And so it's an exciting opportunity because for us it's really a win-win. We get to help out this generally underserved population that People's Community Clinic serves. So these people are either uninsured or underinsured, or they have Medicaid, or like these MAP patients. So we get to be involved with helping them, as well as grow our business with a new referral source and new relationships with these physicians. So it's just a really exciting opportunity to be involved, and I'm really grateful that each of y'all are willing and able to be involved with it too, because I see a lot of potential for a lot of good to happen in a lot of different ways. So as far as some of the logistics of the study, there's some important details here that still really need to be ironed out, honestly, but there are a few key things I want each of y'all to be aware of. So these patients' plans of care can be managed well, and the quality of the study is upheld. So again, all these people will have acute low back pain. Before I see them, they will have done the Start Back screening tool, which will put them into a low risk, medium risk, or high risk category. Low risk will be seen by just me, and I'm only there at the clinic on Tuesday mornings from 8 to 12, so once a week at this point. It might grow to twice a week, we'll see, but right now it's just 4 hours a week. So my ability to see it'll be mostly new patients I'll be seeing, and then the low risk follow-ups maybe every other week or something. Hopefully they're good with just a home program. And then medium risk patients will be sent out to y'all's clinics without also receiving behavioral health. And then high-risk patients, again, based on the Start Back screening tool, how they're stratified, they'll be sent out to y'all's clinics as well, but they will also be receiving behavioral health at the PCC clinic. So these medium and high-risk patients, just managing their plans of care might be a little tricky just because there's still some unknowns, and I wanted to tell you what is known and then ask for your input on some of the stuff that is unknown. So each time you see them, it'll be a flat rate of $80 per visit. They may have up to a $10 copay. The way they explained it is just they try to collect it. Basically, they didn't give me clear guidelines there, but basically, if they have a copay, it could be up to $10, and they try to collect it. But at PCC, it sounds like sometimes they just don't end up collecting it. The funds are paid by the study, so it's not like we're trying to justify care to Orthonet with our documentation quality. So the note quality doesn't have to be as good as it would be to justify care to an insurance necessarily, but it will be important to communicate, because I'll have seen them for the initial visit. You'll be able to find their note in RevFlow and get hopefully a good enough idea of what's going on with the person to start with them for what would be their second visit and your first visit with them, and kind of hit the ground running. It'll be up to y'all to decide how to schedule them, whether you want to put them on your schedule as an initial evaluation or call them a reeval, but somehow just knowing that they have been seen by me previously, but it'll be your first time with them. It may be a little tricky. Y'all can decide how to manage that with your CCs and other PTs who will be seeing them too. The current plan for managing their plan of care is Dr. Christopher Garrison, who's the PM&R doc and on the study. He's a super cool guy, really collaborative, really speaks our language, really in on the whole P&E concept, and just really clicked well with him when we met the other day. He is to be in on the cases that are not improving, which again, if these people are medium to high risk, their progress might be slower than the low risk. So this is a little bit of the gray area, but what I'll ask of y'all is After 2 to 3 weeks of seeing a patient who might be making slow progress or no progress, to be open to having either an e-consult with Dr. Garrison, probably just Dr. Garrison and or myself, either email or phone consult, somehow getting him in on the case after 2 to 3 weeks. It might be helpful to have a plan of, every 5 visits or so, writing a note with more of a reeval type assessment, as far as like recommending whether involving PM&R would be indicated or not, just so there's these people who might be getting better more slowly, we get Dr. Garrison involved sooner rather than later. I don't plan to need to see them again myself. I think it will be just fine for y'all to be for me to be the eval therapist, and then y'all are the therapist from there on out for these people. If you feel like another follow-up from me would be helpful for some reason, or if I'm later, the people leading the study say it's necessary for me to see them again for some reason, we can do that. But let's currently plan for y'all to be kind of the PT there on out, and then you would be communicating with Dr. Garrison whether or not he needs to be involved. There's probably a lot of details there that still need to be ironed out, and if anything's unclear as far as managing plans of care with these patients, please don't hesitate to email me, call me. You can even call, text over the weekend leading up to next week if things are unclear. The volume right now is not clear either. It's going to be pretty slow to start, but we'll see if there starts to be more patients that are being referred out. That's the goal and hope, obviously. There will be some Spanish-only speakers. So thanks to Tony and Yessie from the William Cannon Clinic. Yessie will be the sort of the go-to bilingual care coordinator. So if I see a Spanish-speaking patient, I'll have them call Yessie before they leave that day to get on the schedule somewhere at a clinic and y'all have already contacted or communicated back to me who is able to see them and not able to see them, so they can find a place who is able to see them as a Spanish-only speaker and also who's conveniently located for them. So yeah, again, I know this didn't cover all the details. I just wanted to keep this video short enough to give you some bite-sized, info, and then if you have any follow-ups, again, feel free to call or email or text me leading up to next week, and of course throughout the study as well. The duration of the study, I'm not exactly sure. I think it's like 100 patients or something, but ideally, we can have relationships and referral sources that extend beyond the duration of the study, with this, if we can really put a good foot forward with these people. So again, it's a pretty neat opportunity. It's a win-win, right? We get to help the underserved population while still growing our business. So thanks to y'all for being involved with it, and I'll do my best to be in communication with you throughout. Just reach out if and when you have any uncertainty or lacking clarity on something with managing patients or details with these people. Thanks again. Have a great weekend.